Good evening, everyone. I am Dr. Vinita Ramnani, Chairperson, Scientific Committee, MP State Ophthalmic Society. I welcome you all for the fifth webinar of REVA Division, Preceptors of Future. That's a competitive PG program. And our PGs are very enthusiastic and they are preparing so well. We have judges and our coordinators. The coordinator is Dr. Shweta Walia, Dr. Pankaj Chaudhary, and Dr. Aditi. And with this note, I invite Dr. Shweta Walia to introduce today's speakers and mentors and give the rules for the Preceptors of Future program.
Thank you, Dr. Vinita. We welcome you all to this session of Preceptors of Future, REVA Division. And today we are having 10 participants. They are from Chitrakoot and from the REVA Medical College. As judges, we have Dr. Navjot, Dr. Shubhra, Dr. Manav, Dr. Amit, Dr. Himanshu. The judging will be done on the basis of quality of presentation, way of presentation, relevance of content, adherence to time, and the discussion, the question answers that are asked. Each of these will be judged out of 20, and so your presentation will be in total out of 100. The presenters today are Dr. Prathamesh Agashe, and his mentor is Dr. Gautam Parmar. Second is Dr. Drashti, and her mentor is Dr. Alok Sen. Third is Dr. Aishwarya. Her mentor is Dr. Navjot Singh Aluwalia. Fourth presenter is Dr. Akshita Gupta, and her mentor is Dr. Rakesh Shakya. Next participant is Dr. Ashi Jain from REVA. Her mentor is Dr. Sujata. Next is Dr. Dhirendra Pandey, and his mentor is Dr. Charudat Chalisgaonkar. Next is Dr. Pankaj Kushwa, and his mentor is Dr. Sujata. Next is Dr. Sonu Badole, and his mentor is Dr. Anamika. Next is Dr. Urvashi Dwivedi, and her mentor is Dr. Charudat Chalisgaonkar. And the last participant will be Dr. Kavya Bansal, and her mentor is Dr. Anamika Tiwari. So best of luck to all the presenters, and hoping to have a great session and discussion. And we welcome you all. Thank you.
Thank you, Dr. Shweta. I welcome Dr. Pankaj Chaudhary. He is a backbone and he is just compiling all the results. And I am happy to announce Dr. Palak Patwa as a winner of our last Jabalpur division. And the mentor is Dr. Navneet Saxena. So congratulations, Dr. Palak Patwa. And you have to be there on 9th of April for the final round. So with this, we start with today's program of REVA Division, which includes the Chitrakoot and REVA Medical College. So from SNC, I invite Dr. Prathamesh. So the right name to start, Dr. Prathamesh, please start your presentation. And he will be presenting on the Fuchs endothelial dystrophy. And his mentor is Dr. Gautam Parmar. So Dr. Prathamesh, you can start. Your time is 5 minutes. You can keep the watch on a time. And I request Dr. Pankaj to start the stopwatch and keep a timer on. Dr. Shubhra, Dr. Shweta, and Dr. Navjot at this particular moment will judge the presenters. Thank you so much, Dr. Prathamesh. The mic is on yours.
Hello, am I audible?
Yes, you are audible, but please join your Zoom screen, please. There's a green share screen button. You can press that button.
Yes, ma'am. Good afternoon, everyone. My name is Dr. Prathamesh Agashe, and my mentor is Dr. Gautam Parmar. And topic of today's presentation is Fuchs endothelial corneal dystrophy. It is also known as endothelial corneal dystrophy. It is a non-inflammatory, sporadic, or autosomal dominant dystrophy involving the endothelial layer of the cornea. The endothelial layer is responsible for maintaining corneal dehydration by blocking entry of aqueous and actively pumping out excess water. And loss of endothelial layer results in corneal edema and hence loss of transparency. There are two forms of this disease: early onset and late onset. On the right here, we can see a normal endothelial image on specular microscopy. So the genetics of the disease are it is in two forms. Early onset form is caused by mutation in the collagen 8A2 gene, and this defect is inherited in autosomal dominant pattern. And the late onset form is associated with FECD gene. It is associated with increased number of CTG repeats in the CTG 18.1 sequence in the TCF4 gene. And other genes involved in the late onset form are KANK4 and LMC1 gene. And these can be sporadic or autosomal dominant in inheritance. The basic pathology of these diseases that the endothelial cells are more varied in size, known as polymegatism, and more irregular in shape, known as pleomorphism. And there is loss of endothelial cells, and these are disrupted by excrescences of collagen, known as gutata. So in this image, we can see here that the endothelial cells are larger than normal, and these dark spots are suggestive of gutata. And primary dysfunction of the endothelial cells results in increased cooling and deposition of collagen and extracellular matrix in a thickened descemet membrane. The clinical features of the early onset form are it is associated with formation of bullous keratopathy or corneal blisters within the first few decades of life. And the late onset form usually presents in the fourth decade of life or later, and symptoms start after the age of 50 years. There is a decrease in vision, contrast sensitivity or glare in the early stages due to edema, and rarely it can be due to confluent central guttae without any edema. And pain is due to ruptured bullae or microcystic edema. The symptoms worsen after waking up due to decreased surface evaporation from the corneal surface during sleep, which leads to more edema in the early morning. And pain may reduce once subepithelial fibrosis occurs because this results in reduction of formation of epithelial bullae. This disease is divided into 4 stages. Stage 1, corneal gutata are first evident centrally and then spread towards the periphery. And in some patients, the disease becomes stationary at this stage. And the gutata may become confluent and show a beaten metal appearance, as seen in this image here. And the guttae of late onset FECD are larger than the guttae of early onset FECD. In stage 2, endothelial decompensation occurs with stromal edema. In stage 3, there is bullous keratopathy with increased descemet membrane and corneal thickness, and the central corneal thickness can increase beyond 1 millimeters. In stage 4, there is subepithelial fibrosis, scarring, peripheral superficial vascularization secondary to chronic corneal edema. The management of this disease, early morning blurred vision or minor pain due to corneal edema and bullae can be reduced with hypertonic sodium chloride drops or ointment instillation, and other measures taken to reduce the intraocular pressure. And topical or oral carbonic anhydrase inhibitors can actually decrease the endothelial pump function and increase corneal edema. Hence, these should not be used to reduce intraocular pressure in these patients. And restoration of vision requires keratoplasty. If there is significant stromal scarring in late stages, full thickness keratoplasty is needed. But in early stages, if there is less scarring, penetrating keratoplasty has been replaced by endothelial keratoplasty, either DSEC or DMEC, which is descemet membrane endothelial keratoplasty. In cases where the guttata are confined to the central cornea, descemet stripping only with the addition of topical rho kinase inhibitor like netarsudil to stimulate the endothelial proliferation can be done. And this DSO eliminates the risk of endothelial rejection as well as the prolonged steroid treatment, steroid drops which are required in patients with DSEC or DMEC. However, this DSO may have a prolonged postoperative course, and this treatment method is still under trial. If keratoplasty cannot be done, persistent or severe pain can be managed with anterior stromal puncture, bandaged soft contact lenses for extended wear, and placement of amniotic tissue or conjunctival flap surgery. However, bandaged contact lenses, which are the most commonly used conservative management, require prolonged and repeated follow-ups. And these are my references. Thank you.
Thank you, Dr. Prathamesh, for presenting so well the Fuchs endothelial dystrophy and its management. Now the topic is open for discussion. Judges can ask the question to Dr. Prathamesh.
Dr. Prathamesh, excellent presentation by you. I have one question. If a patient is presenting at late age and what differential you should keep in mind to rule out Fuchs dystrophy, to differentiate it from aging changes in the endothelium, from that of Fuchs?
Ma'am, first of all, we'll see gatte which are more in the central region, which are then spreading towards the periphery. There can be significant corneal edema and stromal edema, uh, and there will be epithelial bullae which are not seen in age-related changes.
So
And
what are these age-related deposits that are seen, that known as on the endothelium? Do you know about Hazel-Henle warts?
yes, ma'am, I've heard of that.
So how will you differentiate them from the guttata of Fuchs dystrophy?
Ma'am, I don't know.
Okay. The Hazel-Henle warts, they are usually in the periphery. The guttata of Fuchs endothelial dystrophy, they are more centrally located, rarely in the periphery. And when you see the ultrastructure electron microscopy, which is not available everywhere, but if it is available, the fissure is seen in the Hazen-Henle warts and not in the guttata of Fuchs. This is the main differentiating feature. Otherwise, very nice presentation, Dr. Prathamesh. Thank you.
Thank you, ma'am.
Yeah. Shweta ma'am, hello.
Yes, Dr. Navjot.
Yeah, ma'am. Can I ask one question?
Yes,
Vinita
yes,
ma'am?
you have to, please.
Yeah. Prathamesh, so what are the precautions you will take, like while you're operating this case? Like which viscoelastic would you like to use if you are, and what is the cell count, minimum count you would like to have before operating? Like where from, like what is the cutoff, like what is the cutoff
Uh,
you would
so
like to
while
maintain?
operating,
Yeah.
yes, we would like to use viscoelastics which are having high adhesiveness, so they will and low cohesivity. So they will coat the endothelium and protect the endothelial cells from damage.
Mhm.
And the endothelial count cutoff, we have to prevent the endothelial count from going below 500, which is the critical.
Please, your comments, ma'am, please. Hello.
Yes,
Vinita ma'am.
Navjot, you can complete your sentence. Then I can you can answer your question. Is he answered correctly or not? Then I will give the comments.
And we'll try to have an endothelial count of at least 1000, so that there will be
Exactly.
less chance
So
of post-operative
the borderline cutoff is
edema.
actually they take is 1000. So if it is below 1000, then it is very risky, and you should use more and more like dispersive, and even you can use a soft shell technique also.
Yes.
Okay. Vinita ma'am, your comments, ma'am.
Yes. With the Fuchs endothelial dystrophy, most of the patients, they can be asymptomatic. They may not present any symptoms and they just come for a cataract surgery. So you have to look into the endothelium very carefully. And your purpose of doing a cataract surgery is not to enhance that problem. Otherwise, on a cursory examination, you can just ignore the fundus, ignore the corneal finding, and you can straight away jump to the cataract surgery. And you may miss Fuchs, and post-op, there could be more of an endothelial damage, and such patients, most of the time, they require that endothelial keratoplasty or a penetrating keratoplasty post-surgery, because most of the time that Fuchs is being missed by the cataract surgeons. They have a tendency to look into the cataract directly, and then the minor changes which are already there in the endothelium is being missed. And if there is a little more handling during surgery, and what Dr. Navjot has said, if you don't use the soft shell technique of doing a phacoemulsion, or if you don't give attention to the endothelium, so the remaining endothelium is going to get further damage, and they can present with an unexpected endothelial loss and the corneal edema post-op. Most of the time, the cataract surgeon, they feel this problem that my surgery went so well, but still the cornea is not that good.
Yes, ma'am. Yes.
Thank you, ma'am.
Dr. Shubhra?
Hello. I missed a few questions because of connectivity issues, but I just want to know one thing. Can you tell me what is coefficient of variation and hexagonality on specular microscopy indices?
Yes,
Am
ma'am.
I audible
Coefficient of
to you?
variation. Yes, ma'am.
Okay.
Hello. Yes, ma'am. Coefficient of variation refers to the variance in the size of the endothelial cells, and hexagonality is expressed as a percentage of how many cells are having hexagonal shape. So, the coefficient of variation is increased in cases of fuchs dystrophy because of loss of endothelial cells. So, the remaining endothelial
Yes.
cells undergo hypertrophy to compensate, and because of that, because of loss of remaining cells, there is irregular shape and hence loss of hexagonality of the cells.
Okay. What are the normal values of CV and hexagonality? Can you tell me?
Ma'am, hexagonality is I think 60 to 80%. The
It
normal
should be
CV
at
values
least
I'm not able to
60%.
remember.
At least 60% cells should be hexagonal. And what about CV?
CV value I'm not able to recollect at the moment.
Coefficient of variation should be less than 33 to 40% depending upon the age of the patient. Thank you, Prathamesh.
Okay, ma'am. Thank you, ma'am.
Thank you, judges. Now we move on to our second presentation by Dr. Drishti. She is also from the Chitrakoot, and the mentor is Dr. Alok Sen, and she will be presenting on beast skin.
Good afternoon, everyone. Hello.
Drishti, your screen is not connected. Please share screen. Yes.
Ma'am, am I audible?
Yes, yes, you are audible and visible too. You can start.
Should I start?
Yes, please, Drishti.
Good afternoon, everyone. Today I'm presenting a topic on the B scale. B suggestive of the brightness in 1958, first time bomb and Greenwood co-developed the B scale. Ma'am, it is not moving.
Not moving? Yes, it is moving now. It is moving, Drishti.
Yes,
You can start. And be calm and comfortable. Coolly, you can present. No problem. You can start, Drishti. It is visible here.
ma'am, it's not moving.
Okay.
So please reset the timer. We are going to start now, Drishti. Be cool and present your B scan.
Good afternoon, everyone. Today I'm presenting a seminar on the B scale. B suggestive of the brightness. In 1958, first time Brom and Greenwood co-developed the B scale. In our ophthalmology, we use such a high frequency 8 to 10 megahertz for the high resolution. Coming towards some terminology related to B scan, first is echo. Longitudinal wave. When longitudinal wave travels to the one medium to the another medium, the part of wave may reflect back towards the source, and this reflected wave called as echo. When there is a greater the difference between acoustic impedance between the surface, we'll get a stronger echoes. Acoustic interface is a junction of the two different media that have a different acoustic impedance. The strength of echo depends on the size, shape, and the smoothness. Angle of incidence, it is the angle at which the sound will strike in the interface. When the angle of incidence is equal to angle of reflection, we get a stronger echo. So we have to put the probe perpendicular to the eye. Gain, it is the ability of the examiner to adjust amplification of the echo signal. It is in this case we only change the intensity of the returning echo. It is like a remote control button, volume control button in the remote. This is a parts of machine. This is a transducer of probe. In this pulsar and receiver is present. This is a receiver machine. Is present in the retina department. It is based on the pulse ecosystem. When the electrical stimulation stimulate the piezoelectric stimulation, it produces it undergoes mechanical vibration and produces a longitudinal wave. It project into the ocular tissue and reflected to the transducer, and it goes to the receiver system, and is a electrical signal, and it produces a two-dimensional image in the display machine. These are some mitigations of the opaque in the clear medias. In our discipline, we do a 3 type of examination technique: transverse, longitudinal, and axial. In transversal, we put a probe parallel to the limbus. A marker of the probe should be parallel to the limbus. We get the circumferential or the lateral extension of the lesion. In the longitudinal, we put a marker of the probe perpendicular to the limbus. So we get posterior extent. In axial scan, we have to put the probe in the primary position. These are the pictorial representation of the different type of systems. In a special technique, we have to do topographic, quantitative, and kinetic ecography. This is the axial scan showing a hyperreflective structure suggestive of the cataractous lens. This is an echolucent cavity suggestive of the vitreous cavity. This is hyperreflective structure suggestive of the retina, choroid, and sclera. This is a wedge-shaped defect suggestive of the optic disc. In the depression in the suggestive of the
Dr.
depression.
Latika, can you mute yourself?
Hyperreflective reflective echoes at the ONH with back shadowing suggestive of the optic disc descent. In vitreous cavity, we have to differentiate astral halosis for the vitreous hemorrhage. In astral halosis, we get a clear space between the particles in posterior globe. In vitreous hemorrhage, we have to low reflectivity. In retina, there is a smooth open funnel with or without discontinuity, but always incident aura with variable amplitude and with marked or moderate movement, suggestive of the posterior vitreous detachment. When there is an irregular high reflective membranous echo, always attached to the disc and the aura reta with poor after movement with high reflectivity, 100% reflective, suggestive of the retinal detachment. In the periphery, we get a smooth, thick, dome-shaped detachment with no disc attachment and with no after movement and 100% echo, suggestive of the choroidal detachment. In the trauma, we have to rule out always intraocular foreign body. There is hyperreflectivity showing the intraocular foreign body, suggests the metal or the stone foreign body. In the infection, in ophthalmitis, there is always vitritis is present. So vitritis looks like on the V scan like a multiple clump or the membrane like vitreous echo with irregular retinal surface because of the inflammation, and there is increased retinochoroidal thickness with elevation of the optic nerve head. In posterior scleritis, we get a classical scleral thickness and choroidal thickening with classical T sign. This is a T sign. In ocular cysticercosis, we get echolucent cyst with echo-dense nodule suggestive of this convex. In orbital scan, we do a transocular and paraocular scan. In the tumor, in the retinoblastoma,
your time is up, Aishwarya. You can continue, but your time is up.
Intralesional hyperreflective echo with the sound attenuation, this is classically stereo appearance. In retinoblastoma, we'll get a collar button appearance. We do a B scan to rule out various extraocular muscles. This is the oval-shaped defect in the echo-dense orbital tissue, such as lateral rectus, and this is the middle rectus and superior oblique. This is my reference. Thank you.
Thank you, Dr. Drashti, for presenting the huge topic of B scan, which is very important for the posterior segment evaluation. Now the topic is open for discussion.
Dr. Drashti?
Yes, sir. Good afternoon.
Excellent presentation by you, covering all the pathologies of retina in such a 5 minutes time. I have just one question. What is the indication for doing UV scan in a case of retinal detachment?
Ma'am, first of all, we have to differentiate whether there is we have to locate the retinal detachment mainly in the opaque media, like there is a conjunctive lens or there is a dense vitreous hemorrhage. We have to first confirm there is a retinal detachment is there or not. We have to locate it. Sometimes we have to do a B scan to locate a tear also.
And what other can be the indication where you really want to know in what cases of detachment, even if the
And yes, we have to differentiate from the rhegmatogenous to the exudative RD. In also that case, we do a B scan.
if the media is clear, the retina is visible. In those cases, seeing going for a B scan is actually not indicated. When the patient has solid RD or the pressure is raised in patient presenting with RD, then we need to know whether there is any tumor that is causing increase in the pressure. In those cases, B scan is indicated. And what is the hyperreflectivity in intraocular foreign body? You said it is hyperreflective, hyperechoic.
Whether it is a metallic or the stone body, will get a hyperreflective. But whether it is a wood or vegetative metal, will get an intermediate type of hyperreflectivity. And in case of the, especially in the glass, if the especially in the case glass, there is if the sound wave strike perpendicular to the foreign body, then and then we'll get the reflectivity. And if there is a spherical foreign body, we'll get a classical cometary cell because of the radification.
Okay. Thank you.
Hello, Drashti. How will you differentiate between? Hello, can I ask?
Yes.
Yes, please.
Hello, Drashti. You presented a very vast topic nicely. Can you tell me how will you differentiate exactly between an exudative and a rhegmatogenous RD by B scan ultrasound?
Ma'am, in the rhegmatogenous RD, there is a after movement is there. And low after movement, but there is after movement. In the exudative RD, there is classical change, shifting fluid cell will get in the exudative RD, so it is absent in the rhegmatogenous RD. And we'll get we'll see the SRF, like in the rhegmatogenous RD, we get clear SRF. That is in the exudative RD, we get low reflectivity back to the retina also. So
okay, yes, you are correct in a way. Basically, in exudative RD, there are absence of folds and rugae, and you will see more of a convex and a smooth surface. And of course, the phenomena of shifting fluid, as you rightly said, that is seen in exudative RD, that is with the change in the position while doing the B scan, the SRF that will take the most dependent position. And in rhegmatogenous RD, you can see rugae, you can see breaks also. Okay, thank you, Drashti.
Vinita ma'am, can I ask?
Yes, please, Dr. Najjo, do the honors.
Drishti, you presented very nicely. It was a very vast topic. You presented it really in the stipulated time very nicely. I just want to ask you one thing because I am a glaucoma person. So can you tell me like in which mode can we see the optic disc cupping very nicely?
Sir, for the specific for optic disc cupping, we use a axial scan. Because in the transverse and longitudinal, we mainly do from the periphery. So in that case, we use the also. And even though in the transverse can we also get optic disc cupping.
No, but actually in the axial, because the lens is coming in the way, the transverse mode is better for the optic disc cupping actually. Yeah. Okay. Thank you, Drishti. Thank you. Thank you very much. Thank you, ma'am.
Thank you. You have to see the excavation carefully. So doing an assessing the cupping on a B scan, it is little tricky. So you have to be careful. And if the media is hazy, sometimes it is not that easy. You have to just see the skeins in one particular skein. It will be very prominently visible. But as said by Dr. Navjot, the transverse will be better. Now we move on to third presentation by Dr. Aishwarya. And he will be presenting on dry eye treatment. So be specific because it's a very vast topic of dry eye management. and the mentor is Dr. Navjot. So,
Good afternoon, ma'am.
please.
Am I audible?
Yes.
Good afternoon, everyone. Today, my topic of presentation is dry eye management. It is not moving.
So please stop this timer and let him move his slides first, then we can start.
Good morning. Today's topic of presentation is dry eye management. The TFOS due to has redefined dry eye as a multifactorial disease characterized by loss of homeostasis of the tear film instability and hyperosmolarity associated with ocular surface inflammation and damage. The classification of dry eye has traditionally been into evaporative dry eye, which consists of about 80% of the cases aqueous deficiency and a mixed variety. The approach towards management should consist of asking of triaging questions like what is the symptomatology of the patient, how severe are the symptoms, then the risk factor analysis, diagnostic test which should include screening tests in the form of questionnaires and the homeostatic markers in the form of non-invasive breakup time, osmolarity and staining patterns, and also the subtype classification test to divide it into aqueous and evaporative. Risk factor analysis should include evaluation of the age, as increased age is associated with aqueous deficient dry eye. Female gender is more predisposed to aqueous deficient dry eye, associated connective tissue disorder or skin lesion, the presence or absence of bovine gland disease, contact lens use, refractive surgery or environmental factors. Here is the image showing the OSDI questionnaire of which value greater than 13 and the DEQ5 questionnaire which uses a screening mechanism and the value of OSDI than 13 and TS and this questionnaire value greater than 6 is suggestive of dry eye. The clinical evaluation and investigation should which must evaluate the patient for vision, slit lamp biomicroscopy, especially to look for MGD, Shermer's test 1 and 2, Jones facial secretion test, tear meniscus height, tear field breakup type, rose bengal and dissemin green staining, and impression cytology. Here is the image showing the filaments associated with severe conjunctival and circumciliary congestion and superficial corneal vascularization, suggestive of inflammatory pathology associated with dry eye. And here is the various staining patterns on the fluorescent microscopy. The various grading system for the conjunctival staining includes the National Institute grade, Oxford and Van Bijwell grading system, of which the National Institute is the most prevalently used. The another modality which can be used is the ocular surface analyzer, which takes into account non-invasive breakup time, lipid layer analysis, bovine gland status, and the tear meniscus height. The dry eye severity is graded into 1, 2, 3, and 4 according to the following parameters: the ocular surface disease index score, the TFBOT, the corneal staining, conjunctival staining score, Shermer score, and MGT score. Here is the image showing the MMP9 test as MMP9 values greater than 40, 49 are suggestive of increased inflammatory component in dry eye, and topical immunomodulator should be started as early as possible. Here is also image showing IPN osmolarity kit and tear lab osmolarity as increased osmolarity greater than 308 milliosmoles. There is a suspicion of increased osmolarity component, and osmoprotective agent should be started as early as possible. It is not moving. Lifestyle modifications. First of all, as soon as the patient is diagnosed with dry eye, we should start by giving him lifestyle modification, which includes improving the ergonomics. In IT professionals, screen should be placed at a level of eyes lower than 10 degrees. Education and reassurance of the patient regarding the chronicity of the disease should be explained. Smoking, alcohol, and caffeine intake should be decreased as they decrease the lipid film stability. Treatment of MGD, which should include warm compresses, antibiotics, lipid flow, and intense light pulse therapy should be done. Coming to artificial tear consists of various preservatives, of which the benzalkonium chloride is the most dangerous in percentages greater than 0.005. Ionic purpose preservatives like Subzia are non-preservative on coming in contact with the environment. Electrolytes must include sodium, which is the mainstay for maintaining osmolarity. Potassium is used for maintaining the goblet cell function and glycogen content, and bicarbonate, which helps in corneal epithelial healing. Main are the viscosity agent, which helps in the ocular surface retention time, and which includes cellulose derivatives like carboxymethyl cellulose, hydroxymethyl cellulose, hydroxypropyl methyl cellulose, hypermellose, the polyols, and viscoelastics. Among the viscoelastics, the main ones are the sodium hyaluronate and chondroitin sulfate, and osmoprotectives includes the erythritol, and the L-carnitine. The inserts are once daily administration. The most popular ones are the Lacrisert, which is a once daily administration and provides increased tear film thickness for 12 hours. Another modality which can be used is the carbamazepine 980, which is a gel formulation with absorbent properties. The autologous serum eye drops have also been tried in patients with Shermer score less than 2, and it is used in concentrations ranging from 20 to 100% and has shown effectiveness in about 60% of all the treated cases within 10 days of use. Anti-inflammatory therapy includes cyclosporine available in 0.05 and 0.1%, tacrolimus 0.3%, loteprednol, doxycycline, which has anti-metallo-matrix metalloproteinase activity, and lipitigras, which is a LFA1 antagonist, and which is a currently new modality of treatment. The secretagogues, which include the dacquazole 3% in Japan and 2% in Europe, rebamipide 2%, and tablet pilocarpine 5 mg thrice daily. Surgical management is used in cases of intractable dry eye to reduce clear secretion, punctal plugs, which can be
Your
divided
allotted
into
time is over. Your allotted time is over, but continue to complete.
punctal plugs include reversible, irreversible, and temporary plugs, suturing, cautery, glue, patching, and eversion of puncta and excision. To continuously supply tears, artificial tear reservoirs, transposition of the tension duct, and transplantation of the salivary gland cells. Here is the first image showing the reversible cellulose punctal plug, and the second image showing the silicone punctal plug. The surgical management also includes reduction of the surface area of the exposure, which includes tarsorrhaphy, surgical blepharotosis, botulinum toxin. Here is the image showing the lateral tarsorrhaphy. Other tried procedures include amniotic membrane transplant, transplantation of oral and nasal mucosa, limbal autograft, and sequential keratoctomy. The take-home message is the step-ladder approach should be followed for patients suffering from dry eye, where step 1 includes education and counseling of the patient, use of lubricants, and the treatment of other allied disorders. The step 2 should include preservative-free eye drops, chamber spectacles, punctal occluders, topical steroids, and topical immunomodulators. The step 3 must include oral secretagogues, contact lenses with rigid gas permeable and scleral contact lenses, and autologous serum. Step 4 should include topical steroids for long duration, amniotic membrane graft, and permanent punctal occlusion. These are my sources. Thank you.
Thank you, Dr. Aishwarya, for presenting dry eye. As I told you, because your topic was a dry eye treatment, so you could have started from treatment and you should have insisted on a treatment which you rushed in your slides. So you presented very well, but you could have emphasized only the treatment. So the main treatment is prevention, the causative treatment, and then a supportive treatment. So with this, the topic is open for discussion.
Hello, Aishwarya. Can you
Yes,
please let me know about certain systemic medications that can lead to dry eye?
Ma'am, most common medications which have been associated are the antidepressants, then beta blockers. Aspirin has also been postulated to cause dry eye, and oral contraceptive pills have also been reported to cause dry eye disease.
What is the association of hormone replacement therapy with dry eye?
Ma'am, actually, increased androgen content is associated with dry eye disease, ma'am.
Okay, there is a controversy regarding the role of hormone replacement therapy, but recently a large cross-sectional study found out that with the increasing dosage in hormone replacement therapy, there is an increase in the severity of dry eye symptoms. So in post-menopausal women, a history of hormone replacement therapy also needs to be elicited in case of a dry eye disease.
Yes, ma'am.
Thank you, Aishwarya.
Thank you, ma'am.
Dr. Aishwarya, do you know about filamentary keratitis?
Yes, ma'am. Actually, for filamentary keratitis to happen, there should be abnormal mucus associated with punctate epithelial erosion. So the combination of two will lead to formation of filaments which move on eye blinking.
And how will you manage filamentary keratitis?
Ma'am, the best way to manage filamentary keratitis is manual removal of the filaments. Also, N-acetylcysteine and other mucolytic agents can also be used for the removal of filaments.
So is N-acetylcysteine available commercially? Or you need to prepare it?
Actually, no, I am not. I have no idea.
So in India, it is not available, and you can formulate it with the injection that is available in the market. It is available in concentration of, I think, 200 milligram per ml, and then you can reconstitute to a lower percentage of 0.1% or 0.05%, whatever suits the patient. You can see if it is irritating or not. And if it is not irritating, you can go with a higher concentration of 0.1%. And if it irritates, you can reduce it to 0.05 or 0.025%.
Okay.
Besides removal of the filaments and everything. What are the three components of the tear film?
Ma'am, first is the lipid layer, then the aqueous layer and the layer of mucin, ma'am.
Yes. Okay. Thank you.
Is there any role of omega fatty acids in dry eye management?
Yes, ma'am. According to a report published in JAMA Ophthalmology, they have said that omega-3 fatty acids have a beneficial role along with vitamin D therapy. They act as immunomodulators and help in decreasing the ocular surface inflammation.
Though they are very widely prescribed, but basically it has been seen that there is some improvement in the clinical signs, but very little change in the symptoms of the patient with omega fatty acid supplementation. That is as per a study in the Cochrane database that analyzed around 34 RCTs, that there is very little improvement in the symptoms of the patient as such. Thank you. Thank you. That was my last question.
Yes, Dr. Navjot.
Hello, Hanji. Yes, ma'am. Dr. Aishwarya, see, I don't know too much about dry eyes, but I just want to ask you one thing. How do we choose so many jobs are available nowadays?
Sir, your voice was cracking in between, sir.
Navjot, your voice is not clear.
Oh, sorry, ma'am. I will repeat my question, ma'am.
Yes.
Yes, sir.
Dr. Aishwarya,
Yes,
see,
sir.
I don't know too much about dry eyes, but what I'm asking you is there are so many drops and compounds available in commercially in the market nowadays. So how do you choose these, like which to use when? Like sodium hyaluronate, polyglycol, and HPMC, and so many others.
Yes, sir. Actually, sir.
How do you choose? Yes.
Sir, there is a stepladder approach that is to be followed. First, in less severe cases,
No,
we can
I'm
start.
just asking. No, I'm just asking you about like in these drops only, not the other things, not the oral or the steroids and other
Yes,
things.
sir. The best drops are considered to be the preservative-free ones, but they are costly. The drop should first of all consist of very low preservatives like vanishing preservatives or Sobzia. Secondly, sir, if the patient if the patient has severe dry eye, then the lubricants having more ocular surface retention time should be prescribed, like sodium hyaluronate.
Okay. Okay.
Navjot, you could have asked what is the association of the glaucoma and the dry eye. Are the drugs?
Yeah, I wanted to stick to ma'am dry eyes only. So I
No,
just.
so one should be very careful when we prescribe anti-glaucoma drugs, because all
Yes.
these anti-glaucoma drugs, they can enhance the dry eye, and
Yeah.
your results will be fallacious as far as the applanation is concerned. And because of the severe dry eye, patient may not be able to perform well on perimetry. So glaucoma evaluation and treatment with medication, if they have a dry eye, you have to be very careful. Even when you do an applanation, you can see the tear film breakup time as it is when you put in fluorescent into the chamber, definitely you are going to see the tear film breakup also. So that's an indirect way of assessing dry eye, because with the excessive use of digital gadgets, the dry eye is increasing day by day. So very well presented, Dr. Aishwarya. Now we move on to our fourth presentant, which is Dr. Akshita Gupta, again from Chitrakoot. The mentor is Dr. Shakya, and she will be presenting use of mitomycin C in ophthalmology.
Good afternoon, everyone. Ma'am, am I audible?
Yes, your screen is visible. You can make it full screen and start.
Yes, ma'am.
Perfect. Akshita, you can start.
Yes, ma'am.
So you are the junior most amongst the four.
Ma'am, Prathamesh and me are batchmates.
Okay.
Yes, ma'am. So good afternoon, everyone. I'm Dr. Akshita Gupta, and the topic of my presentation is mitomycin C in ophthalmology, and my mentor is Dr. Rakesh Shakya, sir. Ma'am, my slides are not moving actually.
You can go in presenter view that previous speaker has done. You can click on a right. So please hold on for a time. She has not started. Yes, it is moving now.
Yes, ma'am. Sorry for the delay.
So the timer starts now. Please see the time. Okay, start, Peter.
Let us again.
Can somebody from Ajanta help her?
Ma'am, I'll fix it once again, please. Sorry for the inconvenience. Yes.
Yes.
Good
Okay.
afternoon,
Be relaxed
everyone.
and present coolly.
Yes, ma'am. The topic of my presentation is mitomycin C in ophthalmology. So coming to the introduction, mitomycin is an anti-neoplastic antibiotic agent isolated from the soil bacterium Streptomyces caspitosus. So mitomycin C first found its way into ophthalmic use in 1969 in Japan, where recurrent pterygium were successfully treated with the drug. Clinical pharmacology. It is an antimetabolite with anti-proliferative effect on the cells, showing the highest rate of mitosis by inhibiting the DNA synthesis. And the reduction in quinine and loss of the methoxy group within the cell converts mitomycin C into a bifunctional or trifunctional alkylating agent, which cross-links the DNA and inhibits it. So coming to the pharmacokinetics, the drug is highly bioavailable to the target tissue in the presence of conjunctival and corneal epithelial defects, and its hydrophobic character favors its penetration into the epithelially denuded cornea and conjunctiva, while deterring its movements into or through the intact epithelium. The use of mitomycin C eye drops, even at the highest dose used, does not result in any detectable levels of mitomycin in the blood. So drug reconstitution, the drug is available in a vial 2 mg and 10 mg, and it is further reconstituted with the normal saline, either 5 ml for 2 mg vial to make 0.4 mg per ml solution, or 10 ml for 2 mg vial to make 0.2 mg per ml solution. Mitomycin C should be reconstituted in normal saline at neutral pH, as the drug is inactivated in the acidic solution. The drug should be stored under the refrigeration to preserve its potency, and after reconstitution, mitomycin C is potent for a period of 2 weeks. So the uses of mitomycin C in ophthalmology are in ocular surface tumors, glaucoma filtration surgeries, pterygium surgery, dacryocysto rhinostomy, squint surgeries, and the refractive surgeries. So coming to the ocular surface tumors, these include a variety of neoplasms originating from the squamous epithelium, melanocytes, and lymphocytic resident cells of the conjunctival stroma. So mitomycin C selectively inhibits the DNA synthesis and is cell cycle non-specific. Consequently, the rapid cycling tumor cells are treated, while the slow cycling stem cells are probably left unaffected. Now, second one is the glaucoma surgery. In the filtration surgery of the glaucoma, the subconjunctival or the scleral scarring at the bleb leads to high failure rate of the trabeculectomy. So mitomycin C inhibits the fibroblast proliferation and subsequent scarring of the filtration bleb in the filtration surgery. So how do we apply it? The merocell sponge over which the mitomycin C is applied at a concentration of 0.2 mg per ml is kept for around 1 to 5 minutes, generally subconjunctival or sometimes subscleral also. And after that, it is thoroughly washed with the balanced salt solution. So you can see the merocell sponge, which is soaked with the mitomycin C, or a subconjunctival injection of MMC, as can be seen here, is also recently being studied. So it can lead to various complications also, like late bleb leaks, bleb infections, endophthalmitis, thin-walled cystic blebs, as can be seen in the picture, corneal epithelial toxicity, corneal or scleral melting, hypotonia or hypotonic maculopathy. In the pterygium surgery, adjunctive use of mitomycin C in pterygium surgery is reported to be a safe and effective procedure, and 0.2 to 0.4 mg is applied intraoperatively over the bare sclera for 1 to 5 minutes. So it prevents the recurrence of the pterygium. Fourth one is the dacryocystorhinostomy, and the major cause of DCR failure is fibrosis occurring under the flaps near the osteotomy area. A piece of cotton soaked with 0.2 mg per ml MMC is applied intraoperatively over the anastomosed flaps and the osteotomy area for 5 to 30 minutes to inhibit the fibrous proliferation. In the squint surgeries, when applied intraoperatively, it helps in reducing the post-op adhesions following the strabismus surgery, and the dose should be 0.2 mg per ml for 5 minutes between the conjunctiva and the sclera. In the refractive surgeries, haze formation with loss of corneal transparency and surface irregularities are the major complications. The use of MMC is intended to inhibit the wound healing mechanisms, leading to subepithelial fibrosis. So a single application of diluted MMC 0.0% solution following the scraping of corneal surface is effective and safe in treating haze and regression after the photorefractive keratotomy for myopia. So there can be various complications of mitomycin C also, and they depend upon the following factors: dosage, route of delivery or application, time of exposure, area of the tissue that encounters the drug, and the higher MMC concentrations and prolonged exposure can lead to increased risk of the complications. The complications can be minor or major.
Continue. Your time is over. Continue to complete.
The minor can be ocular pain, photophobia, lacrimation, the edema or the foreign body sensation, and the major can be scleral ulceration, necrotizing scleritis, as can be seen in the picture, perforation, uveitis, cataract, glaucoma, and symblepharon formation. So the conclusion is the dose and the duration of application of mitomycin C is still controversial, and the use of topical mitomycin C in ophthalmology is increasing in every subspecialty, but risk-benefit ratio should be considered, keeping in mind its complications. Thank you.
Thank you, Dr. Rakshita, for so well presentation of uses of mitomycin C in ophthalmology. And we know it is being used with caution in various conditions, as you enumerated. Now the topic is open for discussion.
In ocular surface disorders, how is mitomycin C used?
Ma'am, it is used. Ma'am, it is used in a concentration of 0.04%. It is used in a concentration of 0.04% 4 times a day, and it should be used in the following manner, like 2 weeks on and 2 weeks off.
Okay, and you'll formulate since it can be kept only for a period of 2 weeks. You have to reformulate the bottle after a gap of 2 weeks. Not the same drug should not be used in the second cycle.
Yes, ma'am.
And in trabeculectomy, you mentioned that the merocell sponge dipped in mitomycin C is kept for 1 to 5 minutes.
Yes, ma'am.
So the same merocell.
Dr. Richa, can you keep yourself muted, please? Dr. Richa?
So I was asking, the same merocell sponge will be kept for 5 minutes, or you will keep on changing it every minute? Any difference in efficacy? Dr. Akshita?
Yes, ma'am.
Huh.
Ma'am, we can keep it like in most of the surgeries. It is used on an average duration for a duration of 3 minutes, and in the range of 1 to 5 minutes, and it can be used continuously for 3 minutes also. But it should be restricted to a time period, because the high concentration and the high duration of mitomycin C can cause various complications.
So ideally, what we prefer is that we keep a Merocel sponge or a pledget soaked in mitomycin C for 1 minute.
Yes.
Change it again after 1 minute. Keep another pledget, and then after 1 minute again. So 3
Okay.
pledgets are kept
Okay.
separately, one after the other. So the total
Okay.
duration being 3 minutes.
Okay, ma'am.
And in the complication, you have not mentioned about the scleral melting. If I had missed, I think.
Ma'am,
So what is the incidence of scleral melting of intraoperative use in cases of pterygium?
Yes, ma'am. Ma'am, I don't know the exact number.
So scleral melting is very high post pterygium, and we usually prefer topical eye drops the same way we use for ocular surface disorders post-op.
Okay, ma'am.
Okay. Thank you.
Dr. Shweta, I don't use every minute. I use continuously for
Continuously.
whatever period it is being decided to put in. So we can change the percentage if you want to have it again. Like you can keep 0.4 for 2 minutes. You can keep 0.2 for 2 minutes continuously. Like that I do. I don't change.
Okay.
Yes.
What?
Dr. Navjot, do you change?
Yes, ma'am. Yes, ma'am. Yes, ma'am. We also change the concentration mostly depending upon the case to case. Like if we are doing a case where the failure is high, then we change the concentration mostly. And I just want to ask you one thing, Akshita. Just one thing. There is there is a very common complication with this mitomycin use also.
Sir,
I mean,
during the glaucoma surgery.
Yeah. Mostly. Can you?
Complication to what she's asking, like at what
Yeah,
either eye
related to-
complication or any other complication beside eye?
Yeah, with the application, ma'am.
It is only eye complication or without
Eye complication.
any other
Eye
thing
complication.
outside the eye also?
Eye, ma'am.
Eye.
Ophthalmic complication. Yeah.
Sir, it can lead to, in high concentrations, it can lead to scleral ulceration and scleral thinning.
One complication which we sometimes, is retained sponges, which we
Okay.
see post-operatively.
Okay, sir.
Sometimes, though it is very rare. So you can have, retained sponges. And we have seen like 1 or 2 cases of, conjunctival melting or even scleral melting in one case.
Yes, sir.
So that is a very common complication with this sponges application.
Okay, sir.
So you
So
have to count
and
the
keep.
sponges.
Count
Yeah, you have to count and keep.
Okay.
Yes, ma'am. Yes, ma'am. Sure.
And one thing I want to highlight that when you are putting in mitomycin C, you have to put a thorough wash after
Yes,
removal.
ma'am.
So it should be a very copious wash, but when you are washing and if you have not used a protection, probably it may go to an ear and it can lead to a deafness. So when you are using a mitomycin C, especially in a lying down position, when the fluid can trickle into the ear on that particular side, so either you have to plug in the ears and then put a drap in such a way that the fluid does not go into the ear.
Okay, ma'am.
That's another precaution.
Ma'am, this is new for us, ma'am.
Oh. So the
ma'am,
deafness has
start
been
putting
reported
spotted
after
from
the
tomorrow
use of.
only.
Yeah, the deafness has been reported after the use of mitomycin C. So you have to be careful that the fluid should not trickle into the ear.
Thank you so
Dr.
much, ma'am.
Shubhra?
That's a new input for us, ma'am.
No, we are learning every day. Like these kids are presenting so well. It is a revision for us also.
Yes, ma'am.
Dr. Shubhra?
Akshita, we know that in ocular surface squamous neoplasia, mitomycin C is used intraoperatively and postoperatively. Can it also be given preoperatively? And in what conditions?
Ma'am, in the ocular surface tumors?
Yeah, OSSN.
Okay. Yes, ma'am, they can be used intraoperatively also.
Yes, they are used intraoperatively as well as postoperatively in a cycle of 1 week on, 3 weeks off.
Yes,
but
ma'am.
can it be given preoperatively too? And in what,
yes,
what are the indications of giving the mitomycin C preoperatively in case of OSSN?
Ma'am, if the lesion size is large, then
Yes.
we can use it preoperatively also along with the post-op doses. And
okay, that is known as neoadjuvant therapy. Neoadjuvant
Yes,
means that is which is given before the main treatment. So in
Yes,
case of large OSSN tumors, we give MMC preoperatively to decrease the tumor size.
Yes,
because excision of a very large tumor that will lead to extensive limbal stem cell loss.
Yes, ma'am.
So besides intra-op and pre-operative drops, it can also be given in the drop form pre-operatively in the case of large OSSN tumor.
Yes, ma'am.
Thank you, Akshita.
Thank you, Akshita. That mitomycin C has to be used with caution, especially in glaucoma. It is used in a secondary glaucomas or recalcitrant glaucoma. So
Yes,
that you
ma'am.
have to keep a mention that the specific indications, probably in a primary glaucoma, we might avoid this mitomycin C.
Okay, ma'am.
With this, we come to fifth presentation. Now it will be from the Riva Medical College. The first presenter is Dr. Ashi Jain, and Dr. Sujata Laktakia is a mentor for her, and she will be presenting on HSV keratitis.
Good afternoon, everyone. Am my screen visible?
Yes, Dr. Ashi, you can start.
Good afternoon, everyone. My topic for today's webinar is HSV keratitis. This is a layout of my presentation. HSV virus is an epitheliotropic DNA virus and typically causes primary and recurrent herpetic infections. This diagram explains the pathophysiology in which the initial infections results in primary infections. Then the virus becomes dormant in the trigeminal ganglions. Reactivation of this virus causes recurrent infection. Primary herpes infection occurs in non-immune persons and has systemic features, skin lesions, and ocular lesions. Ocular lesions can be in the form of acute follicular conjunctivitis or dendritic ulcer. Recurrent herpetic infection occurs when the virus reactivates and replicates and is typically a unilateral disease not associated with systemic features and mainly manifests as active epithelial keratitis, stromal keratitis, metaherpetic keratitis, and herpetic iridocyclitis. The epithelial keratitis patients typically presents with redness, pain, photophobia, watering, and decreased vision. And corneal involvement can be in the form of punctate epithelial keratitis, dendritic ulcers, and geographical ulcers. Among the character staining pattern, the floor of the ulcer stains with the fluorescent dyes and the margin stains with the rose Bengal stain. Stromal involvement can be in two forms, non-necrotizing forms and necrotizing forms. Among non-necrotizing, the two main entities are interstitial keratitis and disciform keratitis. Interstitial stromal keratitis typically manifests as unifocal or multifocal interstitial haze associated with corneal edema and corneal vascularization. Disciform keratitis is a primary endothelitis and occurs due to delayed hypersensitivity reactions. Patients present has corneal and stromal epithelial edema, which is round or oval, folds in Descemet's membrane, iridocyclitis, and increased IOP due to trabeculitis. The necrotizing herpetic keratitis is caused by active viral invasion and tissue destructions and is severe form and shows rapid progressions. Patients typically have suppurative corneal inflammations and present as necrotic, blotchy, cheesy white infiltrates. Iritis and corneal stromal vascularization is common. The metaherpetic keratitis is an epithelial sterile trophic ulceration and typically presents as indolent linear or ovoid epithelial defects, and it's best treated with lubricants, band-aids of contact lenses, and tarsorrhaphy. In evaluating a case of HSV keratitis, after taking thorough history, comprehensive eye examination is done with special focus on slit lamp examination for characteristic features of herpetic keratitis, corneal sensations which are found to be decreased, and IOP measurements. Although the diagnosis is clinical, lab investigations can be used when in doubt. The herpetic eye disease study is a landmark study for the treatment of herpes simplex virus keratitis. According to the study, the epithelial keratitis is best managed with acyclovir 3% ointment. For IOP control, prostaglandins analog should be avoided. Oral antiviral has a role in immunodeficient patients, and interferon monotherapy can also be tried as it speeds up healing. For disciform keratitis, the steroids are given along with antiviral cover. However, if patients has active epithelial ulceration, steroids treatment should be reduced to bare minimum and after antiviral cover. Topical cyclosporine can also be used in such cases. The treatment of neurotropic keratitis is same as that of persistent epithelial defect. While in treating necrotizing keratitis, much aggressive antiviral therapy should be used. Keratoplasty is kept as a last resort for the patients when the disease causes irreversible corneal damage. The prophylaxis of HSV keratitis is important, and it's mainly indicated in the patients having multiple recurrence post-keratoplasty, post-operatively, and in patients with immunosuppressive treatment, and it is given in the form of tablet acyclovir 400 mg. The prognosis is favorable. However, prolonged epithelial or disciform keratitis may lead to scarring and vascularization, and because of which visual acuity is compromised. There are many complications, out of which secondary infection, secondary glaucoma, corneal scarring, and irregular astigmatism are most common. Hence, to summarize, dendritic or geographical ulcer is caused by live virus and are best treated with topical antiviral medications. Stromal keratitis is immune mediated and is best treated with topical corticosteroids along with antiviral cover. So the take-home message is herpes simplex keratitis is one of the most common cause of corneal visual impairment. Although it carries a favorable visual prognosis, recurrences are fairly common, which often results in sight-threatening complications. Hence, timely diagnosis and proper management is important to reduce the burden of corneal blindness due to HSV keratitis. Patients' education has also been made about the hygiene and possible complications. Thank you.
Thank you, Dr. Rashi, for presentation well in time regarding this HSV keratitis. I think in this keratitis, the role of lubricant is very well taken, and also the multivitamins, and just to increase the immunity of these patients because they are having a recurrence. So vitamin D and A as well as the B complex plays the role. Now the topic is open for discussion. Dr. Shubhra.
Hello, Ashi. A very nice presentation and you finished well in time. I have one question. How do you check corneal sensation? We all know that corneal sensations are checked with a wisp of cotton approached from the side, but are you aware of any instrument?
Cockett bonnet aesthesiometer is used, ma'am, and we should always keep in mind that before instilling topical anesthetic drop, we should check for the corneal sensation. Normally we check with cotton wisp, but Cockett bonnet aesthesiometer is ideal to be used.
Okay, very good, Ashi. Can you describe about this instrument a bit?
Ma'am, in this there is an opening in which a fine hair-like projection is there, which is very fine for measuring the corneal sensation, and we should measure in 5 places in the center and in superior, inferior, temporal, and nasal quadrant.
Okay, correct. Basically, it has got a retractable monofilament nylon thread, and variations of the thread can be put on the corneal surface, and the pressure changes with the shorter length of the thread. There is increased pressure. So if the corneal sensation is decreased, then greater pressure or a shorter length of the thread will be used. So we can quantitatively measure the corneal sensation. Thank you, Ashi.
Thank you.
Dr. Navjot.
Ashi, you have presented very nicely and well in time. A very common question we ask to our PGs is like, how do you differentiate from herpes zoster infection?
Sir, herpes
There are
zoster
few
typically has an immunity and typically the vesicles are typically distributed towards the dermatome, and it is mainly unilateral, whereas HSV keratitis can be bilateral. In HSV keratitis, recurrence is common, while in cases of herpes zoster, it provides lifelong immunity. And in the dendrites, in cases of herpes zoster has tapering end, while in case of HSV keratitis, they have terminal bulb and knob end, and the dendritic pattern is very common.
Yes.
Dr. Shweta?
Everything is covered. I think there are no questions. Very nicely covered, Dr. Ashi.
Thank you, ma'am.
Thank you, Dr. Ashi, for such a wonderful presentation. Now we move on to second presentation from Riva is Dr. Dhirendra Pandey. He will be presenting on central retinal vein occlusion, and the mentor is Dr. Charudat.
Is my screen visual, ma'am?
Yes, you can start.
Good afternoon, everyone. Myself, Dr. Dhirendra. I am here to present my seminar on central retinal vein occlusion. So let's start with introduction first. CRVO typically presents with sudden, painless, unilateral vision loss, and it is classified into ischemic and non-ischemic form. And non-ischemic form comprised of 80% of all cases. On contrary to BRVO, anterior segment neovascularization is more common in CRVO. Primary risk factors include age, diabetes, hypertension, and dyslipidemia. Age is the most important risk factors, as more than 90% of cases seen after the age of 50 years. Other risk factors include open-angle glaucoma or vital disorder, vasculitis, and hypercoagulable states. So, pathogenesis. Here is the picture showing retina, choroid. Here is a lamina cribrosa and prelaminar region. In prelaminar region, we can see the small pre-existing venous channels that connects the central retinal vein with the choroidal vein. Now, if the occlusion is present posterior to the lamina cribrosa, then with the help of these collaterals, venous outflow will be redirected to the choroidal circulation, which through vertex vein further drained into superior ophthalmic vein. And such events will lead to the non-ischemic CRVO. But if the obstruction is present at or anterior to the lamina cribrosa, then collateral will be not available for diverting the venous blood, and this will causes ischemic CRVO. So now let's discuss the types. RAPD, poor vision, visual field defects, and reduced B wave on electroretinogram strongly suggest the ischemic event. More than 10 disc diameter of capillary non-perfusion area on FFA also suggests ischemic CRVO, but here is a catch. Firstly, these areas take 3 to 4 weeks to form, as it takes time for the retinal capillaries to obliterate completely. Also, the presence of extensive hemorrhages in acute stages may mask the capillaries. So, FFA does not seem to be ideal choice to differentiate between these two, at least in acute event. In ischemic form, prognosis is poor, as there are more chances of anterior segment neovascularization and neovascular glaucoma. Here is the detailed flow chart to show how the signs and symptoms are developed in non-ischemic CRVO, and here is the in ischemic CRVO. Here, sometimes a young patient may just complain transient vision loss that is worst on waking up, and this may represent an impending form of CRVO, which on FFA may show perivenular hypoautofluorescence and correspond to the patchy intraretinal whitening of retina. So these are the differentials and includes most commonly ocular ischemic syndrome and diabetic retinopathy. So there are some signs indicating past episodes of CRVO and includes optociliary shunt venous collaterals, perivenous sheathing, macular RP degeneration, and epiretinal membrane. Now let's discuss the evaluation and evidence-based management of CRVO. As angle neovascularization is possible even in the absence of iris neovascularization, routine gonioscopy is mandatory. And regarding the management of macular edema in pre-anti-VEGF era, intravitreal triamcinolone suggested to be useful according to SCORE study. And there is no role of grid laser as suggested by CVOS study. In a post-anti-VEGF era, in intravitreal anti-VEGF are the mainstays of macular edema management. And as suggested by Copernicus and Galileo study, intravitreal aflibercept shows the maximum visual acuity improvement among all 3 individuals. Similarly, bevacizumab, ranibizumab were also used to reduce edema and visual acuity improvement. And according to the Geneva study, dexamethasone implant also seems to be very effective, but associated with higher chances of cataract progression and raised IOP. If neovascularization and present PRP is done, and if it is present with closed angle intravitreal anti-VEGF followed by PRP with tube shunt surgery is performed. For the surgical management of CRVO, radial optic neurotomy and creation of choroidal anastomosis has been tried, but these will result in more complications. So by concluding my presentation, if common risk factors were absent or bilateral presentation or age is less than 50 years, thorough investigation including a workup for thrombophilia is considered, and RAPD visual field effects and ERG findings strongly suggest ischemic event. Fundus picture and FFA findings alone in acute stages were not sufficient to differentiate ischemic from non-ischemic CRVO. These are my references. Thank you.
Thank you, Dr. Dhiren, for wonderful presentation on CRVO. What is the name of glaucoma if you develop a glaucoma in CRVO patient?
Ma'am, actually it takes about 90 to 100 days to develop the neovascularization. Hence, it is known as 90-day glaucoma or 100-day glaucoma.
Yes, it is a neovascular glaucoma which is very intractable to treat.
Ji, ma'am.
Now the topic is open for discussion.
Hello, Dhirendra. How will you measure RAPD?
Ma'am, there are basically 2 methods. First is subjective and other is quantitative. By subjective के लिए मैम quantitative के लिए basically मैम subjective के लिए basically swinging flashlight test करते हैं, and for measuring it quantitative neutral density filter is used, ma'am.
Yes. Can you explain it a bit? How are neutral density filters used to quantitatively measure RAPD?
Ma'am, neutral density filters 0.3 की difference में होते हैं. 0.6 से ज्यादा अगर में वो न्यूट्रलाइज होता है तो वो क्लिनिकली सिग्निफिकेंट होते हैं और उसको क्लिनिकली अपीयरेंस ऑफ RAPD मिलता है. इससे कम में मैम RAPD क्लिनिकली अप्रिशिएट नहीं होता है.
Basically, neutral density filters, as you rightly said, they are available in increments of 0.3 log units. The thing to remember is that these are placed in front of the normal eye. And the swinging flashlight test is performed till the pupillary response is equal in both the eyes. This is important because it is a way of differentiating between non-ischemic and ischemic CRVO, and it is found to be a very reliable method of differentiating between the two. In the case of non-ischemic CRVO, basically the RAPD is less than or equal to 0.6 log units. While in the case of ischemic CRVO, the RAPD is more
than
0.9 log units.
Yes.
Okay, you are correct.
Doctor, do we have these filters?
No, ma'am. I don't have any personal experience, but this is something that I have read.
Okay. And what is the role of OCT? You have not mentioned any role of OCT.
Ma'am, it is a best way to measure and to see the macular edema. Macular edema is best seen on OCT, ma'am. And
you can document the macular thickness.
Yes, ma'am. Also helpful in the follow-up of the patients regarding.
Dr. Navjot?
Yes, sir. Dr. Dharan, you have presented very nicely. I just wanted to ask you, so can we not do trap surgery in these patients if we glaucoma? Neovascular glaucoma?
We can do either tube shunt or trab in angle closer patients.
Mentioned in your, I think, slides probably.
Ji sir.
Ji. So then what are the things we will take into account when we are doing this surgery? Like what are the precautions we will take, extra precautions, or you can say?
In
Can you-
trab or tube shunt surgery, sir?
Yes.
Sir, first we have to reduce the intraocular pressure by adding systemic anti-glaucoma in the treatment of patient. And first, we should try to control the IOP. सर पहले तो सबसे पहले एंटी वेजफ देंगे. देन आफ्टर एंटी वेजफ अगर हमें दिखता है कि कुछ न्यूवेस्कुलराइजेशन है, देन अपन पीआरपी करके उसको कंट्रोल करेंगे. और फाइनली अपन अगर उससे भी कंट्रोल नहीं हो रहा है इंट्राओकुलर प्रेशर, देन वी विल गो टू द trab or tube shunt surgery.
But actually, see, PRB and NVF is not for glaucoma control. It is for the control.
It's for neovascularization,
and for creating anoxia, hypoxia, जिसको कहते हैं. So it is not actually for IOP control. The surgery is for the IOP control. Not per se anti-VEGF and this. Actually, you have to give injection before surgery if it is possible, or do a PRB and then you regress the NVI or NVA and all these as much as possible.
Yes.
If you are able to do a PRP, if you are not able to do a PRP, then you give anti-VEGF if it is possible to give. So you can do a trab also before a tube also.
Yes.
Dr. Dhiren,
जी मैम.
How do you differentiate neovascularization of iris from the normal iris vessels that get engorged in inflammatory cases?
Ma'am, neovascularization is mostly seen at the pupillary margin, and normal engorged vessels can be seen anywhere, at the iris stroma or iris bed. And
and they usually regress with a short course of steroids.
Yes.
Very well presented, Dr. Dhirendra. Now we move on to Dr. Pankaj Kushwaha. He is again from the Riva Medical College, and mentor is Dr. Sujata Lattakia, and he will be presenting on endophthalmitis. So it's also a huge topic. So I request Dr. Pankaj to give us only the salient points regarding endophthalmitis, which is a nightmare for all of us.
Am I audible and my screen is visible?
Yes, you can start, Dr. Pankaj.
Today's topic of my webinar is endophthalmitis. It is a purulent inflammation of the intraocular fluid due to infection or inflammation. Progressive vitritis is the hallmark of endophthalmitis. Endophthalmitis can either be exogenous or endogenous. Among exogenous, it can be either post-traumatic or post-operative. Among post-operative, the acute presentation within 6 weeks is most common. Among all type of post-operative endophthalmitis, penetrating keratoplasty has higher incidence. The patient present with acute post-operative endophthalmitis has common symptoms like worsening vision, red eye, pain, epiphora, photophobia, and the hallmark signs are fibrin, hypopyon, and blunting of red reflex. The chronic postoperative endophthalmitis usually occurs more than 6 weeks postoperatively. The frank hypopyon is often absent. Intracapsular plaque with propionibacterium acne can be seen. Stringy white infiltrates and fluff balls are the characteristics of fungal infection, and this often need pars plana vitrectomy. Filtering bleb associated endophthalmitis account 0.2 to 9.6% of glaucoma filtering surgeries. It has increased incidence with the use of antifibrotic agents. If there is blebitis, we should advise conservative treatment. If there is vitritis or acute hypopyon, the needle aspiration of the bleb is contraindicated. Among all post-keratoplasty surgery, the endophthalmitis post-keratoplasty penetrating keratoplasty has higher risk than other type of keratoplasty. Wound adhesion is the common risk factor. Topical steroid should be cautiously used because it increases the risk of endophthalmitis. Among all intravitreal injection, and triamcinolone has shown more incidence of endophthalmitis than the anti-VEGF. Coagulase negative staphylococci is most common pathogen. Triamcinolone acetylide crystal can migrate into AC and mimic hypopyon. We should advise topical steroids and oral fluoroquinolones alone under the close observation. Among all type of endophthalmitis, a traumatic endophthalmitis considered approximately 25% cases, in which 7% are after open glove injury. Bacillus and staph are common pathogen, and all type of endophthalmitis, it has worse visual prognosis. Endogenous endophthalmitis can either be bacterial or fungal. Systemic antibiotics and antifungal should be given to all type of endogenous cases, and intravitreal antifungal can also be given. For evaluation, after thorough history taking and comprehensive ophthalmic evaluation, we should give special emphasis on post-surgical wound leak or dehiscence, dropped lens matter or intraocular foreign body on fundus examination. Dispersed vitreous opacities with vitritis and chorioretinal thickening are the consistent finding on ultrasound V scan. After taking aqueous and vitreous sample collection, we should send the sample for the conventional workup, which should undergo the microscopy, culture, and sensitivity. The newer expanded molecular microbiological technologies like polymerase chain reaction, restricted fragment length polymorphism, newer gene sequencing can be done in higher setting. Vitreous culture are more sensitive than vitreous microscopy. The microbiological spectrum is different in India. The gram-positive cocci has a common pathogen in Western countries, but in India, beside gram-positive cocci, fungal etiology also common. The EVS recommended treatment plan shows if the visual acuity is hand movement or better, then we should advise vitreous stap plus and intravitreal antibiotics. And if there is visual acuity of light perception or with the people with diabetic macular edema, we should advise vitrectomy plus intravitreal antibiotics. And if there is infection worsening at the 36 to 60 hours after the initial injection, then we should repeat the intravitreal antibiotics. For prophylaxis, preoperative topical 5% providine iodine has shown 4.3 times reduction of post-cataract endophthalmitis, and intracranial moxifloxacin and intracranial cefuroxime also has shown reduction of post-cataract endophthalmitis. Also, infective endophthalmitis has various differential, but the toxic anterior segment syndrome has a common entity which shows rapid onset, no pain, and a dramatic response to the topical steroid. Now, the take-home message of my slide, my presentation is the most common etiology is the post-operative. Diagnosis must be made on clinical ground. Acute and fulminant presentation should be differentiated from TAS. Primary objective of endophthalmitis management should be eradication and control of infection, management of complication, and restoration of vision in that order. Thank you.
Thank you, Dr. Pankaj, for a very well presentation of endophthalmitis. It's a kind of an emergency, so you have to act very fast once you diagnose it. What will be the first treatment as soon as the endophthalmitis comes to the diagnosis?
Ma'am, first we should manage the inflammation or infection. After that, we have to manage complication, and after that, we should go for visual improvement.
Yes, so the first thing you should do is to take the cultures, because once you start the treatment, as it is the cultures coming positive, the incidence is less, maybe 60-65%. So you have to take out the cultures first, maybe conjunctival swab, acetate or vitreous cultures, and then you start the treatment. With this, we can start with judges, Dr. Shweta.
Dr. Pankaj, how do you take vitreous stap?
Ma'am, vitreous stap by 27 gauge, 22 to 27 gauge needle, and aspirate 0.1 to 0.3 ml through the pars plana approach, and
So everyone is doing like this only, but the ideal thing is to go with a vitrectomy cutter, because when we
Three-port
take it to
cutter is
the, yes, that is the ideal thing to do when we are taking a vitreous trap. Otherwise, we are putting some vitreous traction. There is incarceration of vitreous
calculation
in
vitreous.
the tract where we are aspirating it. And another thing question is, how do you differentiate endophthalmitis from panophthalmitis
Ma'am,
clinically?
endophthalmitis, it's the prevalence of inflammation just of the intraocular fluid, and in panophthalmitis, it also includes the ocular structure, periorbital structure, periosteum.
Periosteum? Which periosteum?
Sorry,
The whole of the eyeball, including the
eyeball.
coats and Tennant's capsule, is involved in panophthalmitis. And there is the characteristic sign is that patient presents with no PL and there is painful ocular movements.
Movement.
Yes. Thank you.
Yes, Dr. Shubhra.
According to EVS, ceftazidime is recommended for gram-negative bacilli, but a very high resistance has been found in recent studies. Can you suggest some alternative antibiotics for gram-negative endophthalmitis?
Ma'am, intravitreal ceftazidime and intravitreal amikacin.
Actually, that's what I said, that in a recent study conducted by LVPI, the very high resistance has been found to ceftazidime in the Indian
imipenem and
yes, imipenem
and colistin, ma'am, colistin.
Okay, and which is the better of these two, which has a higher susceptibility?
Sorry,
Colistin is considered to be better, but you are right, both imipenem and colistin are recommended these days for if the patient is not responding to ceftazidime.
Dr. Navjot?
Yeah, Pankaj, you have presented very nicely. It's a very vast topic, and in 5 minutes you have finished quite comprehensively.
Thank you, sir.
AC tab also with the tab?
Yes, sir. AC tab with the 27 gauge needle, and the direction should be on the limbus in the trans lamination, and just to avoid the iris plane lens, and we can take 0.2 to 0.3 ml of a.
Yes, yes.
But sir, aqueous culture are not more sensitive than vitreous culture.
Not more sensitive. Yes, correct. Yes. And how do you differentiate it from endophthalmitis in a trap surgery? Is there some differentiating features, if you can specify?
Sorry, sir.
Okay.
Sir, there is trap surgery. There is blab leak or blabitis may present. Also, there is maybe hypopion also present, but
Dr. Navjot, what was your question? You can answer that because we cannot hear the question.
My question was, how do you differentiate blebitis from endophthalmitis, bleb-related endophthalmitis?
Blabitis, the blab becomes opalescent, and
okay. So only thing is that the vitreous involvement is not there in blebitis.
Yes.
Rest you can have hypopion also, but the vitreous involvement is not there in
not present.
CT scan is very important in these patients.
Thank you.
Achha,
So
Pankaj,
there are
one
two
more one more last question, ma'am. Is there any role of fortified drops now, or is it over now?
Sir, according to the EVS, fortified antibiotics has no more visual no added visual outcome.
Added advantage. Yes.
Thank you, Dr. Pankaj. Now we move on to another presentation by Dr. Sonu Badole. He will be presenting on lens-induced glaucoma, and mentor is Dr. Anamika Tiwari. Dr. Sonu?
Yes, ma'am. Good afternoon, ma'am. Is my screen visible, ma'am?
Not yet.
Select no, sure.
Now it is visible, ma'am.
Yes, you can start now.
Good afternoon, everyone. I am here to present my seminar on lens-induced glaucoma under guidance of Dr. Anamika Tiwari, ma'am. Introduction. Lens-induced glaucoma is a secondary glaucoma in which the crystalline lens is involved in the mechanism of intraocular pressure increase. The glaucoma may occur in the open angle or angle closure forms, and there are 5 distinct variants are present. That is phacolytic, phacotoxic, phacoangiogenic, phacomorphic, and phacotypic. Patient typically present with the severe pain, red eye, blurry vision, lid edema, circumcorneal congestion, mid-dilated and fixed pupil, lens particle in AC, pseudohypopyon, hypermature cataract with raised intraocular pressure. In pathogenesis of phacolytic glaucoma, trabecular meshwork obstructed either by lens protein-laden macrophages or soluble high molecular weight lens protein, which causes raised intraocular pressure. Next one is lens particle induced glaucoma, which is associated with disruption of lens capsule by cataract extraction or trauma to the lens, in which IOP elevation because of obstruction of aqueous flow by lens particles. In open angle glaucoma, next one is phacoanaphylactic glaucoma, which is a rare form of the glaucoma in which patients become sensitized to their own lens protein after trauma or cataract surgery, resulting in a granulomatous inflammation. This inflammatory cells obstruct the trabecular meshwork and causes raised intraocular pressure. Most patients typically present with the anterior chamber reaction with KPs, mortar cells and flare, residual lens material in AC, Steinecke formation with elevated IOP. Phacomorphic glaucoma is a variant of angle closure glaucoma in which senile cataractous lens become intumescent and cause pupillary block, leading to angle closure, which may be in the form of appositional or synechial. Risk factor predisposing to phacomorphic glaucoma include smaller eyes, intumescent cataract, traumatic cataract, pseudoexfoliation, and pre-existing narrow angles. The presentation of phacomorphic glaucoma, including shallow AC, peripheral anterior synecdoche, mid-dilated pupil, intumescent mature cataract, closed angle with raised IOP. Now the last type of LIG is phacomorphic glaucoma, phacotopic glaucoma, which is associated with dislocation or subluxation of lens. This dislocation or subluxation of lens may be because of trauma or in inherited conditions like Marfan's and Well-Marchesini syndrome. Pupillary block is the leading cause of the raised intraocular pressure. Now come to the diagnosis of lens-induced glaucoma, which is totally based on thorough history and clinical examination. On other hand, microscopic examination of aqueous also helps to identify high molecular weight lens protein and macrophages in phacolytic and phacotoxic glaucoma respectively. Lens-induced glaucoma is handled as an emergency. Every effort is made to reduce intraocular pressure and inflammation medically with topical aqueous suppressant and topical steroids. Systemic carbonic anhydrous inhibitors and osmotic agents are sometimes needed as well. As supportive methodic can be used. Despite of all efforts, IOP elevation remains a rebound on medical therapy, then definitive treatment is cataract extraction. Laser peripheral iridotomy may be worthwhile, but is often not possible due to corneal edema. My take-home message is the prognosis of LIG patients depend on the underlying etiology. Early recognition of the underlying pathology and timely directed treatment helps to improve outcomes. Thank you.
Thank you, Dr. Sonu, for presenting all 5 types of lens-induced glaucoma. Which is the commonest out of all?
Ma'am, phacomorphic glaucoma is the most entity. Patients typically present with the this form of glaucoma.
And what is the line of the treatment for this phacomorphic glaucoma?
Ma'am, firstly, we have to control the reduce intraocular pressure, and then definitive treatment is the always cataract extraction in this type of.
Will you do or prefer doing combined surgery? And what is the indication of doing a combined surgery for a phacomorphic patients?
Ma'am, there is one study in which doing cataract surgery and cataract surgery with combined surgery. After 7 days, the outcomes of combined surgery is good, but after 6 months, there is no difference between the visual outcome of both treatment arms.
Yeah, but if the patient presents early, maybe before 3 days, you can do only cataract surgery. But then if you don't do glaucoma management for such patients, or if you don't follow these patients, probably they'll end up with optic atrophy. So if it is more than 7 days, probably it is good to do in combined surgery, especially in our scenarios where the patient has reached to the extent of hypermature cataract, not getting the treatment in time. So you have to manage glaucoma. You can't leave them without managing glaucoma. Dr. Shubhra, please.
Can you tell me some common intraoperative and post-operative complications that you can encounter while operating these cataracts? In case of phacomorphic phacolytic glaucoma?
Ma'am, in case of phacomorphic glaucoma, there is the post-op zonal dialysis is most common intraocular complication.
In phacomorphic glaucoma, because of the intumescence of the cataract, there is a very high incidence of rhexis extension. It is quite difficult to do rhexis in an intumescent cataract. While in the case of phacolytic glaucoma, you can have, there is zonular instability because the cataract is very long standing and it has got a hard nucleus also. With the milky cortex, the zonules are quite often weak. There is a higher incidence of PCR also. And a very common post-operative complication that is seen in these cases is a disproportionate and persistent inflammatory reaction. Sometimes in the case of phacolytic glaucoma, a membrane might even be formed over the IOL, which you might need to even break with the Nd:YAG laser. So persistent inflammatory reaction is quite often seen, that is disproportionate and a bit alarming too sometimes.
Thank you.
Dr. Navjot?
Yes, Dr. Shubhra has very well pointed out. Thank you, ma'am, for all your points, ma'am. Dr. Sonu, I just want to ask you one difference is there any difference between phacomorphic and phacolytic in the vitreous cavity? Do you find any difference? There is one thing which we find very commonly in phacolytics in this cavity.
So, sir, inflammatory reaction is a more in type of glaucoma.
No, inflammatory reaction is seen in both the cases. Here we at Chitrakoot we do these cases every day, almost every day. So so you find less matter in the vitreous phacolytics actually. which is not present in phakomorphics. The reaction, post-op reaction is very common in both the cases.
Yes, sir.
In the anterior chamber, but the lens matter in the vitreous cavity is very commonly, sometimes very commonly seen in the phacolytic, not in the morphic.
Yes.
Yeah.
Thank you, Dr. Navjot. Dr. Shweta.
Everything is covered. Everything has been asked.
Thank you.
It
Thank
was
you
enough.
so much. So very well presented, Dr. Sonu. Now we move on to Dr. Urvashi Dwivedi. Her mentor is Dr. Charudat, and she will be presenting on virtual reality perimeter. It's a topic which is very close to my heart.
इसको सेलेक्ट कर
Meanwhile, okay, your screen is visible now.
Good afternoon, everyone. My topic is virtual reality perimeter. Perimetry, it is the systematic measurement of the visual field. It is the essential component of defining the extent and progression of glaucoma as well as other neurological defects. Conventional standard automated perimetry is the gold standard for visual field testing, but it has several limitations. It is bulky and non-portable, expensive, needs maintenance and trained staff, and it is time consuming. Now, it is a virtual reality perimeter. It is special designed to overcome these challenges. It is a head-mounted, rechargeable, battery-operated perimeter and does not need an external power supply. Virtual reality perimeter is a compact, comfortable, and cost-effective. Compact device is compact, light-weighted, and easily portable. Can be used in screening camps. Not required to wear an eye patch. Free to sit in comfortable posture and lesser chances for fatigue. Cost-effective, VR perimeter is cheaper than standard automated perimetry. A teleophthalmology enables cloud-based diagnosis for easy recovery of reports. It has three components. First one is head-mounted device. It is worn by patient to perform visual field tests, and it presents stimuli to patient. It has built-in eye tracker to monitor fixation, and it has adjustable interpupillary distance. Second one is desk controller, which connects wirelessly to headset and contains software that can be used to decide which test type and strategy used. It has cloud storage for data backup. A response button clicker. It is a Bluetooth enabled response button is given to the patient that can use to response when seeing stimulus, and it has easy to grip design. This is the VR perimetry. This is the test controller head mount display, and it is the patient response button. Additional component is backpack for storage, test controller charger, and its head mounted device charger. Device specification, stimulus size is Goldman 3. Background brightness is 31.5 apostrophes. Stimulus presentation time is 200 milliseconds. Stimulus color white and white. Test strategy, multiple algorithm used. Supra threshold, full threshold, and fast. Test pattern 30-2, 24-2, and 10-2. Reliability parameters measures fixation loss, false positive and false negative. Global indices values, mean deviation, total deviation, pattern stand deviation, glaucoma hemifield test, and visual field index. It has device-specific normative data. Test step, first performed test setup, login into test control unit and start the test, prepare patient for test and adjust headset and interpupillary distance, know for patient comfort, and monitor test in progress on test controller. Subject looks at the fixation point and press the response clicker when sees the stimuli, and once test completed, save print and save print test reports. Advantage, no need for dedicated darkroom. It has binocular monocular testing. No need for trial lenses on majority of patients. Patient can also wear own glasses. Can be used for pediatric patients. Reduce test time, increase
patient sensitivity, testing accuracy with active eye tracking. Active eye tracking continuously monitor fixation for accurate and reliable results. If loss of fixation occurred, testing was paused. Verbal notification through the headset, visual notification on tablet for operator, visual notification in headset for patient, and test resumed once fixation is regained. This is the article published on Journal of Glaucoma on January 2021, preliminary report on a novel virtual reality perimeter compared with standard automated perimetry. Result and conclusion of these studies: global mean sensitivity of the virtual perimeter and the HFA correlated significantly in both normal and glaucoma groups. Excellent correlation between the VR perimeter and standard automated perimeter in normal and glaucoma patients, and VR perimeter showing high diagnostic performance. My take-home message is VR perimeter are convenient, comfortable, accurate, and cost-effective. VR perimeter offers a chance to break free of the constraint of the in-clinic testing and make perimetry examination more accessible. These are my references. Thank you.
Thank you, Dr. Urvashi, for explaining the virtual reality perimeter, which is a new perimeter, head mount.
Thank you.
What is the advantages beside you wrote in your presentation? Is there any other condition in which beside glaucoma they are very helpful?
Ma'am, there is other neurological defects, optic neuritis, macular pathologies, anterior optic neuropathies can be used.
Yeah, so beside glaucoma, it is helpful for the neurological patients, especially if there is a pituitary tumor or a bedridden patients, where you have to evaluate the fields. So now the topic is open for discussion. Dr. Shweta, please.
Dr. Urvashi, you mentioned that virtual reality perimeter can be used in children.
Yes.
So what age does it is suitable for? Does it have a normative data for children?
Yes, ma'am.
Also?
In some articles, ma'am, is mentioned for pediatric patients. Ma'am, 8 to 17 years of age pediatric patients was included in some articles. Yes, ma'am. This is a game-based virtual reality perimeter using 24-2. Yes, ma'am.
Okay.
Yes.
What is SWAP?
Ma'am, ma'am, standard wavelength automated perimetry.
SWAP is basically a blue and yellow perimetry.
Blue and yes,
is it possible on virtual reality perimeter?
No, ma'am, there is no article.
Virtual reality is basically a white on white, and blue on yellow is, it also gives when there is pre-perimetric glaucoma or which is not detected on white. For those cases, we go for blue and yellow perimetry, and this is not possible on this virtual perimeter.
Yes, ma'am.
Can we do a progression analysis or follow-up of glaucoma patients on virtual reality?
Yes, ma'am, we can.
So the same GPA analysis.
Yes, GPA estimation and just, yes, ma'am.
Dr. Navjot?
Dr. Urvashi, can you just tell us what is the cost of this instrument? And one more thing, जो इसमें जो statistical analysis है,
yes,
is it possible with because you are saying it can be used in children?
Yes.
उसके लिए तो normative data चाहिए और फिर उसका statistically analysis उसमें possible है, ये मतलब possibility है, तो उसमें
yes,
सारा all the printouts are like the मतलब same as the Humphrey?
Yes, sir. All printouts is the same as HFA, and sir, its cost is approx 3 to 4 lakhs.
Okay.
Yes.
And so, what is the normative data minimum age? Like, what is the age?
Sir, in some, yes, sir. In HFA is the above 18 data, and in virtual reality in some articles it mentioned 8 to 17 years children are included, and there is normative data for children also.
Okay. Okay. Thank you.
Yes, thanks.
Dr. Shubhra?
Just one question. Is it comparable to Humphrey in cases of all glaucomas, that is early, moderate and advanced glaucomas, or are there some limitations of this virtual reality perimeter?
Ma'am, it is used in early, in moderate glaucoma, sensitivity is better. Early glaucoma was missed.
Yes, okay, I don't have any personal experience, but that is what I have also read, that it is basically more useful in moderate and advanced glaucomas, while some improvement is needed to detect early glaucomas because it is still in process right now.
Yes, ma'am.
Thank you.
Thank you.
Yes, very well said. This virtual reality perimeters they are new perimeters. They are at this particular moment, they are considered as a screening tool. It's like an NCT, so it is not going to replace the applanation tonometer. NCT is just like to screen larger population, a population which is not approachable to applanation. The same way we can use a virtual reality perimeter as a screening tool, where the Zeiss Humphrey visual field analyzer or any other field analyzer is not available. But then the glaucoma treatment or the glaucoma progression cannot be based on the virtual reality perimeter at this particular junction. Maybe eventually down the line, we are looking into this. The larger data are not available as far as the comparison is considered. So the statistical evaluation, even for the kids, is not that good. Only thing is, it is easier to perform. So it is being acceptable by all our elderly patients as well as the patients below 18 years, which are having a very difficult having a lot of difficulties performing the test, especially if the patient has a Parkinson's, if the patient has a neck problem, not able to sit on the bowl, or if the patient is claustrophobic because of the dark room or because of that perimeter, they are not able to maintain for such a long period of time because it has a shorter duration. So when we compared our results, we found that it is 3 to 5 minutes earlier you can finish off the visual reality perimeter. So it is just, we are looking forward for this perimeter, but at this particular moment, it is not going to replace the traditional perimetry, which we are doing for our glaucoma management especially. But it is, yes, it is good for bedside perimetry where we, in a pituitary tumor patient, we just want to see there is a bitemporal hemianopia or not. So with this, we move on to our last presentation of today. That is Dr. Kavya Bansal, and she will be presenting on fluorescent fundus angiography. And I would like to thank Dr. Kavya because she has consented only one day before and she has agreed to present in this platform. So welcome, Dr. Kavya. Present your
Thank you, ma'am.
fundus fluorescent angiography.
Thank you so much, ma'am. Good evening, everyone. Is my screen visible?
Yes, you can start.
Introduction. Fluorescent angiography is a diagnostic technique that uses intravenous fluorescent dye to allow the sequential visualization of the blood flow simultaneously through retina and choroid. The light of shorter wavelength is excited and the light of longer wavelength is emitted. It is mainly used to study the normal physiology, the vascular integrity, and of the vasculature of both the retina as well as the choroid, and also to check the integrity of the blood-retinal barrier. Here we can see two filters. One is the blue light filter, the exciter filter, and the second is the yellow-green light barrier filter, which blocks the blue light and thus allowing only the yellow-green light to get captured by the fundus camera. These are the indications and the contraindications. We have to make sure that there is no history of any adverse reaction to FFA in past, which is an absolute contraindication. Coming to the adverse event reactions, these are the adverse reactions. Now coming to the phases, first is the choroidal phase, in which the patchy filling of choroid takes place at 9 to 10 seconds. Second is the arterial phase, where we can see the filling of the arteries is taking place while the veins are completely empty. Then comes the arteriovenous phase, in which the filling of arterioles, capillaries, as well as the laminar flow takes place. Now comes the early venous phase, in which there is a marked laminar flow which can be seen. And in the mid-venous phase, we can see that the laminar flow starts disappearing and the veins start getting filled. And in the late venous phase, the veins are completely filled while the laminar flow disappears completely. Then comes the late elimination phase, where staining of disc is seen. Then coming to the interpretation of FFA, abnormal fluorescence can be in the form of hypofluorescence or hyperfluorescence. Hyperfluorescence may be due to blocking or filling defect. Hyperfluorescence may be due to pooling, staining, window defect, and leakage. Now, first seeing the blockage at the level of choroid, which can be seen in two cases here, as in choroidal nevus and focal RPE atrophy. Here, in both these, the retinal vasculature is completely of normal fluorescence. Similar finding is seen in subretinal hemorrhage, which is of scalloped shape and irregular margins. Then blockage of both choroidal and retinal fluorescence, as we can see in the pre-retinal hemorrhage, where complete masking effect of the hemorrhage causes the hypofluorescence of retina as well as the choroid, and intraretinal hemorrhage, where there is irregular blocking effect seen. Then coming to the filling defect, in the first image, we can see in the color photograph, there is the macula seems apparently normal, but coming to the angiogram, we can see the distortion of the foveal avascular zone as the FAS has increased in size. Coming to BRAO, we can see the occlusion has caused the filling defect at the level of vein. And this is the site where we can see that the embolus has been lodged. Then coming to ischemic CRVO, we can see that it is showing both the blocking effect as well as the filling defect, which is causing capillary non-perfusion areas. And the subretinal hemorrhages are causing the blocking effect. Then comes hyperfluorescence. First causes window defect, which causes unmasking of normal background of choroidal fluorescence. Then window defect can be seen in full thickness macular hole and bullseye maculopathy. In both of these, the RPE and the overlying structures affected, and hence we can the choroids appears hyperfluorescent. Now coming to this is pooling, in which accumulation of dye occurs in closed space. It can be under the retina like CSR or sub-RPE space as in PED. Now in PED, we can see that in the subsequent angiogram, the intensity of fluorescence has increased while the size remains normal. And in CSR, we are seeing the fuzziness of the margins as well as the increase in size. Now coming to leakage, it is due to the extravasation of fluorescent, which may be due to CNV, CME. In CMV, we can see the lacy margins, which is increasing in fluorescence on subsequent angiogram, and in cystoid macular edema, we can see the petaloid arrangement. Then coming to leakage, it may be also due to NVD or NVE, which on this leakage is because of the neovascularization. And staining it is because of the leakage of fluorescent into the tissue or material like in drusen or astrocytic hematoma. Very rightly, we can see it in ARMD. Then recent advances. There is a need to evaluate the periphery of the retina, as it is a site of pathology in many vision-threatening eye diseases. And this is Opto's wide field image, which gives a very wide angle view of greater than 200 degree. And non-perfusion is detected in the, as we can see here. Then take-home message, FFA helps in detecting the type and exact location of pathology, thus guiding the course of treatment. And hence, we always need to interpret with background clinical information. Thank you.
Thank you, Dr. Kavya, for such a wonderful presentation on FFA and completing it in a time.
Thank you.
What is the typical sign of CSR on angiogram?
Ma'am, first is ink blot pattern and second is smokestack pattern. We get ink blot pattern as I showed it in the image. There was an increase in the size of the hyperfluorescence as well as there was fuzziness in margin. And in smokestack pattern, ma'am, there is a linear vertical rise in the fluorescence. And that is because of the differential, there's an osmotic difference between the RPE and the serous fluid, that is mainly protein filled. That is the reason for that.
Perfect. Dr. Shweta.
Hello, Dr. Kavya, and wonderful presentation. I just wanted to ask, what is FAZ?
FAZ is, ma'am, foveal avascular zone. It is of 3 millimeter size, that is of 2 optic disc diameter. Ma'am, here the vessels are deficient. There is increase in and there is deficient. We don't get fluorescence here because of First, because of xanthophylls, also because of the absence of vasculature there. And thirdly, because of RPE also having melanin overlying.
In which phase of angiogram do you study about FAZ?
Ma'am,
and why do you need to study FAZ?
Ma'am, FAZ is studied in the later after probably after the venous phase, and also we need to study FAZ to mainly rule out between the ischemia and edema, because in ischemia the FAZ gets distorted and gets increased in the hypofluorescence increases in size.
You are not correct over here. The FAZ is studied at in the early venous phase, when the filling in the arteries and the vein is equal, the fluorescence in arteries and veins is equal, and it is at 20 seconds, not in the later phases. And you need to study FAZ because the size of, if the size of FAZ is more, there are high chances that the disease may convert into proliferative retinopathy if it is more than 500 microns. And also you need to see whether the contour of the FAZ is normal. There are no budding of new vessels into it, intruding vessels are not intruding into the FAZ.
Okay.
That's the need to set. And I would also like to ask, what are IRMAs?
Ma'am, IRMAs are these are the retinal connections, vascular connections between the veins and the arterioles.
And how do you differentiate them from neovascularization?
Ma'am, neovascularization causes leakage in the subsequent angiograms, while IRMAs, they do not leak.
IRMAs may or may not leak, and they are basically connections between two major vessels, and they never cross the major vessels. Okay, and neovascularization is on the surface of the retina.
Yes, ma'am.
They are not intra-arterial, and they will all intraretinal. They always leak.
Okay, ma'am.
Dr. Navjot?
Dr. Kavya, I just want to ask you one thing. Is it necessary in all diabetic retinopathies that you have to do FFA, or you can treat it without doing FFA also?
Yes, sir, we can treat it without FFA also if we can if we can clearly see vascularization and demarcate the area as well. But FFA is gold standard, since microaneurysm is the characteristic feature of diabetic retinopathy. They cause focal leaks.
So, but you can see microaneurysms like that also, no? With your eyes.
So sometimes they can be missed on clinical picture, on clinical examination. And we can get confused between microaneurysms and dot blot hemorrhages.
Okay. And one more thing is now Octa has come now. OCT angiography has come.
Sir. Yes, sir. OCT angiography.
Sir. Yeah. So do you still require this like FFA, or can it tell like some differences?
So OCT angiography can be used wherever FFA is contraindicated, like in renal diseases, like in the first trimester of pregnancy, and also in patients anyone having allergy to fluorescent dye. Their OCT angiography, since it's a non-invasive investigation, we can definitely use it in those cases. Yes, sir. And OCT provides a better dynamic flow because of the movement of the RBC cells, and in macular edema we can quantify it better in a better way by OCT.
So you are saying that where it is contraindicated, there you can use Octa.
Yes, sir.
But so in the normal patients who do not have all these problems, we can use Octa in place of FFA. This is what you are saying.
Yes, sir, we can.
Okay. What is that like in the normal patients who doesn't have all these problems? So what is the advantage then of FFA over Octa. FFA over Octa, not Octa over FFA.
Sir, FFA helps us to सर FFA choroid का इतना अच्छे से नहीं बता पाता है the details, but the details can be very well they can be very well measured and located in OCT angiography. That is one more advantage of OCT A over FFA.
But I think whereas these can be seen in FFA, I think.
So in FFA, choroidal vasculature is
no,
not.
FFA, we can see the leakages, no? So which vessel is leaking from where?
Yes,
Whereas I think that we cannot see in in Octa.
Ji, sir.
Yes.
Octa is very expensive. It is not available at many centers. So FFA is considered as a gold standard.
Yes, ma'am.
Dr.
Shweta ma'am,
Shubhra?
any points from you or Shubhra ma'am, please?
As we discussed about the FAZ, it can't. As we discussed about the FAZ, no, the FAZ can't be quantified on Octa. It is better seen on angiography, and when you need to see the after laser, if you want to keep the patient on follow-up and you want to see if you want to do an again you want to give a setting of laser in which areas you want to do, in that definitely FFA will be better. Octa will not define the areas where you need to give touch-up laser.
Yes, Dr. Shubhra.
Ma'am, no questions from my side. Everything has been covered and asked to. So since this is the last presenter, I just want to congratulate all the participants. Excellent presentations by all of you. Irrespective of who is the winner, I think everyone presented quite well. So congratulations.
Yes, very true. The PGs are presenting like consultants. They are having confidence. They are presenting their slides very well. So thanks to their mentors, Dr. Shashi and Dr. Sujata, I can see. So any closing remarks?
Yes, good afternoon to everybody. Yes, every presenter has presented very nicely, and they this is I congratulate all the participant, but I also appreciate and congratulate to Vinita also. This is your view. This is your view, and you have started this Preceptor of Futures. This is a very good tool for the PGs, so they learn and they have ability to present and how to they develop confidence for the presenting in their conferences. I appreciate your action. It's very good.
Thank you, ma'am. It is all because of all your efforts from the medical colleges, coordinators and judges. They have been there from past 5 Sundays, and then it's really good to see the enthusiasm in the students, and I should congratulate all the mentors, like they are in contact with the postgraduates.
Good evening, Dr. Vinita, Dr. Shubhra, Dr. Shweta, Pankaj sir, Shashi ma'am. This is Dr. Navjot. It was a wonderful afternoon and evening. I was thinking that a Sunday afternoon spent on educational stuff might be a little boring, but I have been illuminated, so to say. It was a wonderful, wonderful presentation session, ma'am. Dr. Vinita, thank you so much for giving us the opportunity to be a part of this wonderful educational experience. Lovely questions from Dr. Shweta, Shubhra ma'am, Dr. Navjot. I have been enlightened. I have learned so much from today's session. Thank you so much, all of you, and kudos to all the presenters. Mentors, of course, do a good job, no doubt about that. Ultimately, the credit goes to the presenters. They have been very hardworking. They have all done their part very well. And it was a wonderful evening. Thank you, Dr. Vinita, once again. And thank you, all the judges. Thank you so much.
Thank you. Thank you. Dr. Richa, are you there?
Just 1 minute, ma'am.
Navjot, please.
Yes, ma'am, I just want a few words from Dr. Pankaj sir also, ma'am, please.
Yes, yes, definitely. He is the backbone. He is going to declare the results.
Yes, sir. Pankaj sir, please, sir. Please, sir, your
And
comments, sir,
he
please.
is so humble
Yes,
and he is
yes,
so
sir.
true. Sorry, Pankaj, I need to say this. He said, Madam, I am not going to judge because it is the REVA presentation. So he is so true. Like, I just appreciate Dr. Pankaj on
Thank
this
you, madam. Thank you for
particular
that.
thing.
But I would like to thank all the REVA divisional candidates, those who presented today. And I'm so proud of my candidates that they have presented so nicely. Not only the REVA, all the presenters, because now they are learning, see, so many things are available online. But how to edit and take the time in the consideration, they have made it very nicely. Special to mention Kavya, only in 24 hours she has prepared the same. So it was a very good presentation by all. So I would like to congratulate the team of REVA division. Special to mention Dr. Anamika and Sujata, the mentors. They are always the preceptors since so long and making them so good. So the presentations are good. Your idea is good. That is working very good. They are presenting this seminar to our seminar room nicely. But when they have to present here, with the competition to the others, they are preparing it better. So definitely they are going to improve better. Thank you.
Thank you, Dr. Pankaj. And I hope we all are also learning because they are such a basic things. As a clinician, probably we don't read. So that's a good thing. Maybe you people are there in the medical college, you are teaching, but those who are clinicians, probably they are not reading. So I think this type of presentations by PGs enlighten us also.
Yes, correct.
Exactly, ma'am.
Dr. Richa, are you there? Okay, so with this, we conclude our REVA division webinar, and the last will be the Ujjain division and a few of the leftovers Indore division students. So after this, we will declare the results, and all the winners, the first ranked in each division, they will compete with each other. So there will be total 6 participants which will be presenting a case for 4 minutes, and there will be a rapid fire quiz round of 2 minutes, and then there will be judges from the conference which is there on the 9th of April at Jabalpur, and the winner will be declared, and let's hope all will present well, and may the best win. So thank you so much, all of you, for being with Preceptors of Futures. And I hope same type of participation in coordination and enthusiasm in future activities of MPSOs. Thank you so much.
Thank you.
And I would like to thank Ajanta Pharma for their good thing that they are organizing the webinar. They are into the time, they are producing certificates, and they are giving us the opportunity to meet online, sitting at home coolly. So thank Mr. Sanjay Jain and Sapna for giving this opportunity. Thank you so much.
Thank you.
With this remark, we will close. Thank you.
Thank you, ma'am. Thank you, everybody.
Thank you.
Navjot.
Thank you, sir.
Bye-bye.
Bye.